Floor is yours, Doctor.
Well, thank you very much, and it's certainly a pleasure to be here and look forward to talking to you all a little bit about AI. I don't have any commercial conflicts of interest, but as you heard, I am somewhat of a shill for organized medicine with my involvement in the college, and currently I am the Chief Medical Officer for the ACR's Data Science Institute. And with that, I believe that medical specialty societies can be in the middle of the AI ecosystem between industry and software developers for our members that are the end users of the tools, and then the regulators. And so before we start some of the specifics of breast stuff, I wanted to talk to you a little bit about what we've done at the Data Science Institute and some of what we've learned about AI. First, we believe that ethics are obviously very important, and the Data Science Institute, among others, participated in the creation of papers on ethics and data sharing that talk about transparency, dependability, and mainly that radiologists still remain ultimately responsible for what happens to our patients when we're using AI. The ACR participates with many other organizations in the United States around health equity to ensure that we look at AI with a culture of fairness so that underrepresented and vulnerable populations don't get disadvantaged. Some of those ways to mitigate potential bias are understanding why bias develops, transparency in the algorithm development, what were the data sets that were used, identifying the populations at risk, and then assuring that there are economic resources so that underserved people can do that. So I want to tell you about a paper that was done by a data scientist, radiology at Emory, that AI can recognize race even when radiologists cannot. And it was radiographs, ultrasound, CT. It was an amazing project. And so if the models then can understand race or ethnicity or some other factor, could it possibly introduce bias? And so this is a made-up case about a lesion that might be detected, but if there's an ethnicity assessment and that there's a high risk, well, there it would be. But if there was a low risk, well, maybe the model wouldn't worry as much about it. And so those are the things that can happen in the background that we as radiologists are going to have to understand to mitigate bias and ensure transparency. I think that from our perspective, we believe that radiologists are going to have to understand why they need to evaluate AI algorithms for use in their practice, and to do that, they're going to have to understand some of the basics of AI. The FDA, in general, is the U.S. regulatory body, and in general, they are on our side. They say that consumers should expect the same level of safety in software devices as they do for other medical devices. And when you look at the spectrum of things that are available for breast imaging, most of them have to do with things that the FDA doesn't regulate, the non-interpretive AI, if you will. And so the interpretive AI is really what they are regulating: detection, diagnosis, triage, and segmentation. And for those, FDA clearance will be required. For AI, radiology seems to be the medical specialty so far that's getting the most attention from this chart from the medical futurist. If you look at what was shown in AI in 2019 at the RSNA meeting, you can see all of these companies that were there. At the ACR, we track what's been cleared. There have been 214 AI tools that have been cleared. And in mammography, we've got about 21 for diagnostic mammography, 4 in ultrasound, and 3 in MRI. And I think that that's bound to escalate. And I think that the FDA and other regulatory agencies are going to feel pressure for how they clear it. We have built a tool to help end users, our ACR members, but it's freely available, called AI Central, where you can look and see the tools that have been cleared. You can sort them by, excuse me, subspecialty or body area or modality. And this is just sort of a list of some of the things for breast imaging. And when you drill down on a single one, you can see those documents that they've released from the FDA that showed sort of the product information. But it's really not enough. We need more public information about how the AI was developed, what the data sets look like, are the characteristics of the data set going to be similar to what we have in our own practices to help use that. And so right now, regulatory clearance alone may not be enough to assume that it works. And I want to extrapolate that to the people that believe that AI can be an answer in underserved areas. If you bring a model that was trained in the United States or in Western Europe or somewhere else and expect it to work just like that in a population in Central Africa without testing and validation in that population, it's liable to break. The FDA has some, good thoughts. They have a nice roadmap of good machine learning practices, pre-market assurance of safety and effectiveness, and post-market surveillance or monitoring. They just don't have any regulation yet that makes developers do that. At the Data Science Institute, we've looked at a couple of these things, so good machine learning practices and pre-market testing. We have our use cases for breast imaging that show good machine learning practices and what are the data elements that are needed and those things. We had worked with the FDA with a workshop about transparency to see what the things that the developers should expose. But at the end of the day, AI models are going to be brittle when they're moved to an environment outside of where they're trained. We have seen that in a number of studies, and it's sort of because it challenged sort of the FDA process. If you have a patient and a single device, you can know that it works. But with the CT scanner, if we have one, that's great. But there are this many CT scanners maybe, and when you start running that same model on all these scanners, it may not work exactly the same. Similarly, an AI model might work in one patient but not in another, or a different model may work on one scanner but not another one. We've seen challenges in ensuring that these models are validated. There's no requirement for external validation, so we've seen several studies that look, and we worry that in these single institution type development processes that there's the risk for overfitting. The European Journal of Radiology published this article about whether to buy or not to, buy a nice checklist. At some of our conferences, we've had people suggest that people build a data set of your own data to evaluate the AI tool before you buy it with enriched cases of uncommon diseases and procedures. At the college, we built a tool called Evaluate AI that helps people do that with your data staying on-prem, but you can run the model in a secure cloud, and you could run different ones, and in particular find one that fits. Now, once you establish the model in your practice, you have to understand that there are going to be changes in equipment and protocols and other demographic factors that are going to the data drift will likely cause the model performance to degrade. So monitoring that and having tools to monitor that. So we offer data registries or AI data registries that can help do that can be used sort of real time in clinical practice to monitor how the model is performing, and and more importantly, collect the metadata so we can understand where it fails. Now, that said, AI may not be perfect, but it doesn't need to be perfect to be beneficial. So if you look at these ROC curves, so here's me, I'll admit it, I'm down here, average radiologist. Here, most of you probably better than me. And we have an expert, say someone who does only breast imaging 100% of the time, and an expert. And we would hope that the AI would be better than all of us. But frankly, it's probably not going to be. But that doesn't mean that it doesn't help some of us, many of us. And it doesn't even mean that radiologists C would never benefit from AI, and that the AI might find something that radiologist didn't. A number of validation studies and a meta-analysis have shown that in general, we believe that radiologists plus AI are better than either alone. Yet there's going to be a big push for AI in mammography and autonomous AI. And as we look at that, this is one tool that's been approved in Europe called ChestLink that will interpret normal chest x-rays, get them off your work list, and it's got the CE mark. And I suspect that even though there's not been any autonomous AI approved in the United States yet, that this will be our first encounter from industry to push that. There's a shortage of radiologists. There are underscreened populations, and I believe that can pretty much be said worldwide. Some of these papers show that if you can have a model that will identify a normal mammogram, then you can reduce both workload and callbacks. And there are a couple of studies that have shown that. And so it gives us promise a little bit for what we could do in other countries. Still, we have to think that if we're going to use autonomous AI, that we have to have a higher standard of what that would be. And so in 2020, we just pointed out to the FDA that we need to ensure generalizability, enforce continuous monitoring, and really too soon to conclude that this is going to be safe. Because you can say, if you look at the 40,000 highway deaths that occur in the United States each year, 90% are due to human error. But that's one human and one event. If the AI makes an error, it's going to be repeated thousands and thousands and thousands of times. And so we really have to be careful, and maybe we should insist that we have superhuman performance with real-world data, real-world evidence. So when we look, though, at the possibility of autonomous AI, we look toward, can we, thought I did this. Excuse me. We look toward how can we impact health equity. And we look at, in the United States, the incidence of breast cancer being fairly equal in African Americans and white, yet the effect of triple-negative breast cancers and access issues make the impact of breast cancer harder on African American people. And then if you look worldwide, you can see that the incidence of breast cancer is less in the underserved, low and middle income African areas, yet the effect on mortality is higher. And so we believe that with AI plus mammography, there might be an ability to do that, to improve that situation. Now, could ultrasound be used? Ultrasound may be more readily available. Cost, portability, handheld devices, all could help us. So I think that we have a lot to look forward to with AI and breast radiology. I think we're not there yet, but keep a lookout over the next few years, and I thank you very much for your attention today.
Thank you very much, Dr. Allen, and now we'll open the session for discussion.